Okay, welcome to the sort of final video that we're going to provide as asynchronous content for the metabolism classes. So we're just going to look a little bit at factors affecting drug metabolism. So we're just going to look at, just a few factors that put a bit of clinical relevance on the content you're learning around metabolism. So let's start with an example mini case study. Let's imagine you're a pharmacist. You work in the pharmacy, two patients are prescribed codeine. One patient comes in and experiences the analgesic effect, is very happy, but another one comes in and they're really wondering why nothing's happening, and they start to lose trust in the ability of the pharmacist to provide an adequate medication. It's a bit far-fetched, but let's just put it in those contexts. The key crux of this is the patient doesn't really understand why the codeine's not working for them. Why is this happening? Well, actually, an understanding of metabolism can actually lead you to get to the root of the problem and explain this possibly to the patient, and also make a sensible recommendation for an alternative therapy. Because codeine is actually a prodrug of morphine. For codeine to work in the body, this methyl ether needs to be cleaved. It needs to be dealkylated via the action of cytochrome P450 enzymes. And only once this phenolic OH is revealed will the drug be able to have the appropriate interactions with the opioid receptor to give the analgesic effect. So the free OH is essential for activity. So if you understand this, then you can start to investigate and solve the problem, because it may well be that the patient number 2 is incapable of activating the prodrug in their body. And there's a number of reasons why, but probably the most likely cause of this would be a single nucleotide polymorphism, which is affecting the cytochrome P450 enzyme that's activating codeine in the body. So first of all, what is a single nucleotide polymorphism? I'm not very good at biology. I'm probably not telling you anything you don't know here, but you have the triplet codes that code for specific amino acids, which are then incorporated into the proteins and enzymes that do everything in the body. So UUU codes for phenylalanine, UCU codes for serine. So of course these sequences, these codes are incredibly long, and in the replication process it's not wholly unlikely that a single nucleotide mistake will be made in the code, and instead of UUU, for example, a UCU will be put in as one triplet code somewhere along this massively long sequence. Okay, so by chance this is possible, but that's quite a profound change, because if the correct triplet code is UUU, which codes for phenylalanine, but UCU is actually read and then coded and transcribed into the protein, then you'll get a serine residue instead of a phenylalanine, and these two are very different amino acids. So that means the structure of the protein is going to change quite profoundly. Now it's possible that, so if you look at that's the structure of phenylalanine, the side chain is just a benzene ring attached via this methylene to the peptide chain, whereas serine has got this hydroxyl functional group. These two will give very different interactions within the structure of the protein, or with any sort of molecule that's binding to the protein. Now it may be that replacing phenylalanine with the serine happens at a relatively unimportant part of the peptide chain, and it won't have any effect on the activity of the peptide. Or it may be that this phenylalanine is a key residue in the active site of whatever enzyme or protein that's being coded, and then that's going to have a profound effect on the activity of that protein. So as we all know from the COVID pandemic, the virus is mutating, or has been mutating all the time, and you've got lots of different variants reported in the media, some of which are more transmissible, some of which are less susceptible to the actions of the vaccines, things like this. And these mutations are occurring through things like single nucleotide polymorphisms, which are changing small residues in like the spike protein of the virus, and therefore having an effect on the activity of the virus. It's the same for catalytic enzymes and things like that. So polymorphism can result in amino acid changes that alter the activity of the protein. So you could get a protein that's even more active. So patients with this type of mutation could be described as extensive metabolizers. course, the mutation could cause decreased or absent protein activity, so some patients can be poor metabolizers. If it's their cytochrome P450 enzymes that are affected, then they will be less able to metabolize drugs than, let's say, a normal person. The mutation could cause altered substrate specificity of the enzyme, and SNPs represent the most extensive genetic difference between individuals. So if you go back to our case, this could well be the problem. It could be that patient 2 has a polymorphic variant of CYP2D6, which is the cytochrome P450 enzyme that dealkylates codeine and releases the active drug in the body. So this patient is just not able to activate this prodrug. And if you know that the patient can't do this, can't cleave off this methyl group, you know they won't get any analgesic effect from the codeine, so you can switch them to a different analgesic. So again, it's a nice example of how an understanding of metabolism can lead to better outcomes for the patients. There are lots of examples of polymorphisms that affect CYP enzymes. So this CYP3A4 isoform is the most important of the isoforms. It's the one that metabolizes most of the drugs. It metabolizes up to 50% of known drugs. Polymorphisms are thankfully rare, and you rarely see any functional consequence. CYP2C9, quite a common metabolizer. You do see allelic variants of this that lead to people who are poor metabolizers. So it'd be well known that some people are poor metabolizers of non-steroidal anti-inflammatory drugs, warfarin, phenytoin, drugs like that. So this does occur in the clinic. Right, next factor that affects metabolism, drug-drug interactions. So drug-drug interactions, obviously, it's a really common thing, particularly in pharmacy. A lot of the basis for drugs interacting with each other can be drawn back to how they affect the metabolism of each other. So let's say you've been treating a heart transplant patient and you've checked for possible drug interactions. When someone's had a transplant, a common prescription is the immunosuppressant cyclosporin, which prevents the body's immune system from rejecting the transplanted organ. Now, if you have a patient who's following all your advice, taking all of this prescribed medication, and they suddenly undergo rejection of the organ that's been transplanted, then you need to be able to work out why. And I believe this has happened before. So let's say this patient who has taken all the medication as prescribed, but they were also feeling a bit low. They went to Holland and Barrett and they decided to take some St. John's wort because they've used it for years as a really effective pick-me-up. The problem with that is St. John's wort induces the action of CYP3A4, which is this isoform that metabolizes more drugs than any other. St. John's wort increases levels of this highly active cytochrome P450 isoform. So what this will mean is this patient will start to break down the anti-rejection drug a lot more quickly than would have been predicted for them. That means there'll be far lower bioavailability of the anti-rejection drug, which is what's leading to the transplant rejection. So again, if you know about these interactions, then you can counteract it, particularly when CYP3A4 metabolizes 50% of all prescription drugs. That's a big red warning for things like St. John's wort, which induce activity of this isoform. If you look at some other examples, some drugs inhibit the metabolism of others. So if you're taking warfarin and chloramphenicol at the same time, that's bad news because chloramphenicol inhibits the action of CYP3A1 and CYP2B2, which are involved in the breakdown of warfarin. So if you're taking chloramphenicol alongside warfarin, you're ultimately going to increase blood plasma levels of warfarin because you're going to slow down the body's ability to break down this compound and metabolize it and excrete it from the body. So there's a lot of mechanisms by which this can happen. Quite often, like as in with chloramphenicol, you have one drug that is a competitive or non-competitive inhibitor of the important CYP enzymes that break down the drugs. You need to know that. You can get the metabolite of a drug that ultimately binds the CYP450 enzymes to form inactive compounds, or you can have certain drugs that can cause heme destruction, usually by acetylation, so drugs like secobarbital or ethinyl estradiol. Some drugs actually induce metabolism. So if you're taking the oral contraceptive, and you're taking rifampin at the same time, again, this is bad news, but it's kind of working in the other way. By rifampin inducing the activity of CYP3A4, that's going to increase the rate at which the body is breaking down the oral contraceptive, which means that you're going to lose that prophylactic effect, and therefore the contraceptive is not going to do the job that's intended for. So if you were to take these two drugs at the same time, you may end up with a bit of a surprise at the end of the month, but luckily we understand these interactions and the basis in the metabolism and how one affects the other, that you can counteract this. Age also is quite important. So people in different age groups differ in their ability to metabolize. It's normally the very young and the very elderly, the people at the two opposite ends of the age spectrum, that are most affected. Sorry, I'm not sure what's happening there. So the very young, they're affected because they're not yet fully metabolically competent. So they have virtually no phase 2 metabolism. So very young are less able to detoxify or break down foreign chemicals and excrete them from the body for that reason. So that's the basis for things like chloramphenicol toxicity, because poor phase 2 metabolism of the drug means that it's not excreted quickly enough, which is what ultimately led to grey baby syndrome. They only have limited phase 1 activity as well, so less ability to break down certain drugs, activate certain drugs as well. So a knowledge of this helps you to provide paediatric care a lot more safely and effectively. So understanding metabolism really feeds into this. That's another reason why it's so important. With the elderly, it's just significantly decreased drug metabolism, just because there's diminished enzyme induction and production. So this affects multiple drugs, leads to lots of drug interactions, and that's why the treatment, another reason really why the treatment of the elderly is so difficult, because of course most elderly people also have comorbidities. They're taking a lot of drugs. There's already the potential for lots of drug interactions, and they've also got decreased drug metabolism capabilities as well. So it's a sort of a vicious cycle, which makes it very difficult to treat these patients. But obviously the pharmacists have the skill and the know-how to get around these issues. And finally, disease. Disease can affect the body's ability to metabolize drugs. So diseases like endocrine disorders, infections and inflammation can have this effect, and very commonly liver disease, of course, because most of the metabolism is happening in the liver. So liver disease has the most significant impact. Very commonly alcoholic liver disease, because as we talked about before, alcohol is probably the most widely used, the most widely abused drug. So alcoholic liver disease, cirrhosis, is actually pretty common, as unfortunately too is liver carcinoma, so cancer of the liver, which again can reduce the liver's ability to metabolize. So if you look at how alcohol affects the liver's ability to metabolize, prolonged exposure to alcohol leads to an inflammation and hepatocytes accumulating, so fatty droplets accumulating in the liver. Continued exposure results in fibrosis and ultimately cirrhosis. It doesn't happen in a sort of a linear drop-off of activity in the liver though. So if you get acute exposure, so let's say you have a short period of time where you are imbibing an awful lot of alcohol, so you get this short-term acute exposure to alcohol, that can kind of sort of temporarily inhibit or limit the liver's ability to metabolize drugs. If you carry on that exposure over a long period of time, actually what happens then is you get induction of metabolic enzymes in the liver, and you get the liver's increased ability to metabolize. So this often I find manifests with people. I used to work in a pub, worked for well over a decade in a pub, and there was plenty of people who would take great pride in telling me how they could drink vast quantities of alcohol and it didn't really affect them. And I always used to tell them that's because they were halfway on their way to cirrhosis, because you do go through this period where you're drinking a lot of alcohol, where you do start to get more active metabolism in the liver due to the chronic exposure to alcohol. But alongside that, you also are damaging the liver by these mechanisms that we've mentioned here, and you're going to go past an optimum level, and then you're going to start to tail off, and then you're going to start to cause permanent, irreversible damage through liver cirrhosis. So yeah, so word of warning, if you are drinking sufficient amounts of alcohol to mean that you're able to drink more alcohol and break it down more quickly, it's not really good news. It's not a source of pride, it's a source of worry, because you're starting to change the function and structure of your liver, and if you keep that up, you're going to cause permanent, irreversible damage to your liver, which is going to be a life-limiting condition. So that's the really cheery message I used to deliver back over the bar when I worked in the pub. It's a surprise that I stayed in the job for so long then. Right, anyway, so I think that's it. So just cirrhosis, I'm probably not very well qualified to go through this really, but I'll give you the basic details. Cirrhosis isn't pleasant. This is where liver tissue is replaced with fibrous tissue, which means you get a decreased number of functional hepatocytes, which are where the metabolism will happen. Cirrhosis has the greatest impact on CYP activity, so you decrease the body's ability to carry out conversions like N-demethylation and oxidations. It doesn't seem to have much effect on phase 2 metabolism like glucuronidation, but it can affect the blood flow through the liver. So, and ultimately, I mean, you get really unpleasant side effects and failure of the liver ultimately. So that's it there, a bit waffly at the end, I do apologise, but just to summarise, there are lots of factors which can affect the metabolism of a drug and lead to clinical manifestations. So understanding metabolism is another tool in your armoury to understanding these things that present in the clinic and being in a position to think of an alternative way around them. So things like genetic variations, drug-drug interactions, diseases, things like that, they can all affect how a drug's metabolized and broken down in the body, which then will also have symptoms for the patient. So the more you understand this, the better your treatment will be. So I hope this helps. Thank you.